Okay. Okay. Good. Why are we here though tonight? If it's one of the first dark, wet Monday nights, there's a quiz on at the pub. As my wife told me, she couldn't come tonight because Corrie's on. Why are you sitting in this room tonight? May I make a suggestion that it's because you probably have some aspiration to support people with either compassion or with challenge, whether it's at the beginning of their life, whether it's at the end of their life. Whether it's perhaps the doctor who's spent hours in surgery and doesn't know if he's done a good enough job. The carers who spend the vast majority of their lives doing what they can for people who are in need. From cradle to grave. Would that be a fair assumption that you've got some interest in making that a better job? The reason IMS exists, and I wrote this, I didn't sit down to write a mission statement. I just wanted to be really clear as to why we were all in the firm and what we were doing. Primarily, it was to reduce errors and omissions that cause difficulties and fatalities fundamentally. We absolutely are here for citizens. And this isn't a mission statement I sort of thought I've got to write, it's got to be in the book. The single biggest area of our economies is healthcare. It's bigger than defence, it's bigger than social care, and it affects everybody, of course. And at IMS, we really strive that everything we do has to be world class, and it's not just, again, something that we write. It has to be, and I'll tell you why, because of the journey that we're on. Now, many of you might have heard of HIMSS, very globally respected statement from them in January 2012 about each year, errors, unfortunately, in the States alone, kill more people than breast cancer, AIDS, and car accidents put together. What really annoyed me was that this was in 2012, and I read the book that came out, it was published in 2000, written by some really brave people in 1999, because I was aware of my travels around the UK and Ireland, and my own experiences that there was a lot of bad stuff going on, or stuff that we could make better. And the one thing that's changed is on the previous slide, in 2012, they noted 195,000 deaths. On this slide in 2000, it was 98,000. So the only thing we've done is counted more. And then around this time, unfortunately, we learned about mid-staffs, and we have our own atrocities, things that really we kind of knew were there, but people weren't looking for them. I should tell you about my team. I'll introduce them if I may. There's 107 of us, I think, today. This is our head office in Dunleary, in the middle here. We're a distributed workforce. I claim that we probably develop 10 times as much software, 10 times faster than industry norms, with probably 10 times as less people in most of my competitors. We have about 25 people in the UK office, about 30 in the Dunleary office, about 22 in Romania, and the rest are distributed either from working from home or on site. And it's a model that I've worked on to create so that we can scale and also keep our costs down. And we call ourselves Team IMS internally because we really are a team. I use the word I a lot, I'm afraid, because I take responsibility. I've been chairman and CEO at my company, and I've been there 10 years this November. We've already mentioned, we support 180 organisations today. It'll be over 200 next year. 30,000 people log in and use our systems. That's clinicians and, well, mainly clinicians. And we have just about 13 million patient records that exist. And I take that responsibility really seriously. I haven't really mentioned myself and what my background is. I'm a dad of 4. My parents are both passed away now. The reason I'm standing here is Bob on the right, passed away 20 years ago. He was my dad. I was already in healthcare, I worked in hospitals, but I decided, I think with algorithms, we could have kept him alive a bit longer. My mum, Norrie, passed away 6 years ago, both in very difficult circumstances. She was the only person in our family that's ever been up in a helicopter. She was air ambulance to intensive care at the end of her life. My father had a very long, slow death with cancer. I also maybe should mention that I thought, my grandparents, I thought when my grandmother died at 80, that everybody had 44 grandchildren and 48 grandchildren when they died. So my experience of healthcare, social care, community care, mental health is probably rather extraordinary. I just thought everybody had these size of families. This is an example of a lady who's in a cardiology unit in a hospital that claimed to have one of the most, or if not the most advanced electronic patient record in the world. Now, this just so happens, I asked her if I could use this photograph. I took the photograph because I wanted to show you this. So this is her coming out of the cardiology unit. At the end of the room was a couple of PCs. Nobody used them all day. And there's a prize for anybody who can guess what that is.
Oops, jobs.
Kind of, yeah, really good. Yeah, oops, wrong way. So it's a paper towel. It's got 4 different handwritings on it, and it is it's her vitals, and that's a paper towel in a hospital that claims to have the most advanced. So I sent out to my team and said, can't believe it, you know. But fortunately, this is my wife, by the way. It just so happens. I sent it to the team and said, look at this, and they knew where I lived and they knew which hospital it was. And I got this one back from our commercial director now, and that was her baby's 2-week-old baby rushed into hospital. That's a bandage. That's a date of insertion of cannula. Something really, really basic. On the back of a cannula today, it says, good practice, write the date of insertion. And I say, no, for 10 years we've been showing you when to take it out so it doesn't get infected. Now, I'm not here to criticize anybody who is doing this, because something must be wrong with our systems if they're having to rely on this. That's a point I think you were making, David. You can't build the systems so that people work around them. Our systems will not work unless we build them around what the people need. And just finally, on this piece, our go live of the first open source electronic patient record was at Taunton in 2015 in September. And I was there, we were about 3 or 4 days in, and I was standing outside a clinician's room waiting for a break in his sessions so I could give him some information. And I saw this in public on a notice, and I'm afraid those at the back might not see it, but it says, please do not tie notes together in piles bigger than 6 inches, thank you, because the string snaps. And if it really has, and this was a good trust to start with, it was using a big American electronic patient record when we replaced it. If that's how bad it's become, gosh. Right, so why did we open source our products? Why did IMS decide to do that? So, to what end? It's quite simple. If you go back to my mission, it's to accelerate making things better. For nearly 30 years at that point, we'd been getting input from clinicians as to what sort of systems we should build. They didn't get anything back from that other than a product. But our company, we had the intellectual property and we charged for that facility. And I thought, well, actually, if we really want to do this, and my mission is global, it is to provide, you know, if the first world can pay for it, let the third world, or the developing world, make use of it. So why not give the software away for free? I didn't invent this. Why should anybody waste their time reinventing something that's already been done? Now, I suppose we've already discussed open source and how it's done, and this is one of my favorites, the Canaletto shows St. Mark's. There is only one original copy of that. And here's one of my favorite books as well. We can all have a distributed copy of that, but can we all use it? And you can't feed back to these systems. And the idea of open source solutions is that you can take them, enhance them, and feed them back. And I'll come back to some specifics that have partly been addressed already. But I did my own research. So after about 25 years, our company has existed. My research director comes to me and says, we really should go open source. And I said, don't be stupid. We spent 45 million quid. You really want me to just give it away? And then I started to think and listen. And the NHS sort of came to us as well. A couple of people who really instigated a discussion. Beverly Bryant and her associate Richard Jefferson said, can we have your product? We said, what, the old one? He went, no, the new one. I thought, you're mad. How do I exist? How can I just give it to you? But I started to think, and I rang up 45 different people from CEOs, nurses, doctors, spoke to them individually and said, what's really important to you in having an electronic patient record? And they said, really, these 5 things. I really want something really safe. I said, what about open source? And they said, it's kind of interesting. But I want something safe. I want something that my people can use. I want it fixed really quickly. I want a great supplier who turns up and doesn't charge me $10,000 every time I answer the phone. The benefits of open source have probably been rehearsed, if not here tonight, then many times. But the big one for me is it is about clinical empowerment. I've been working for software vendors in health for over 20 years. But I've worked in healthcare, in hospitals, buying systems and using them. So I understand both sides of the fence. And I'm not proud of the vast majority of our sector and the adoption of software. I'm really not. But it can give you all of these things, value for money. Vendor lock-in, you mentioned, Tim, that's a great way people use money. What if I just strip that away and say, you choose if you pay me? Because I honestly believe if I provide you with a really great service and job and products, you'll want more of it. And if you don't, I shouldn't be in business. And that is as fundamental as it is. Now, there isn't anything really behind this. We're paranoid in our business, we're paranoid about what people think all of the time. What's the catch? Because there are people who claim to be open source and they're not. What's the catch? There's going to be an extra charge somewhere. You're going to get me with something else. How safe can it possibly be? Oh, and it's got to be easy to hack, hasn't it? Even people in my own organisation have said, but you're really making it unsafe now. Now this is another one of my favourite, it's my favourite Italian restaurant in Manchester, San Carlo's. And I liken open source to this. A lot of people have said, well, I could just do this myself. Why do I need you? Well, I can cook a steak. I can cook pasta. And about 20 years ago, we started tearing down the walls of our restaurants, and you could see inside the kitchen. Now, no one ever goes up to the pass and has a look and says, is it clean over there? Are you tidying up? Is anyone spitting my food? No one ever does that. They've got the confidence that these people are so professional. And my view of open source, or one of the views is, you can look at it yourself, you can test it yourself, and you can help me find what's wrong with it and make it better. After I released my software, I really started to take an interest in Elon Musk. About 2 months after I did that, he open sourced 3,000 patents of from his Tesla portfolio. And I thought, at last, I kind of feel vindicated, because we're building stuff so fast and releasing it so fast. By the time it's released, it's out of date. So people are sort of, hanging on to intellectual property and all of this stuff. And I say, but the more I can give you, the more you can help, the more you can help accelerate the mission that I think, probably the reason that we're all in this room. So on a couple of technical things, we open sourced our product in June. The license meant that anybody who uses it, you have the right to use it. But if you make a change, you've got to let us know so we can decide if we can put that into the product. And when I say we, not we IMS MAXIMS, we the community that sits as a governance body and says, yeah, that's sensible, or yeah, that's not. Now, Taunton, I'm going to come back to in the next one. They were the first people to sign up. They were the first people to take it. And we did something really fast. We did it in about 15 months from contract signature. We went live. We could have done it in 9 months. But we did an amazing piece of development work. Now, I was delighted 2 weeks ago to be in Manchester. Up there's Jeremy Hunt announcing the first NHS Global Digital Exemplars. And I'm really proud that our client Taunton's been chosen to do one. So over the next 2 years, they get a bunch of cash. They get to accelerate what they're already going to do. And we get the privilege to work with them. And it is truly a partnership. If you want to take anything away about IMS and open source, it is this. I am offering you my open source software, and I'm asking you to come and work with me. It's a simple trade. So we released openMAXIMS. Now, there's loads of stuff that we're doing, and we'd be delighted for you to find out more. And I openly invite you to come and see us if you're really interested. But I also openly invite you to make a contribution. Where are we going to go? So we've got a roadmap. I don't know that we published this as such yet, and it's a living, breathing thing, but certainly we've talked about publishing it. The users get it. We update it all the time, but virtually as soon as we've written it, it is also out of date. The main thing we want to do is bring everything from the right to the left. My only limitation and frustration really is that I don't do things fast enough. And that if you ask any of my clients, they'll tell you, what's the problem with IMS? Number one problem, they say, don't deliver fast enough. I can code really quickly. It takes me an age to gather requirements, and if anybody's got to pay for it, that takes, well, I started off as a boy doing this job. It really is, it's frustrating, but we've tried to remove so many barriers to make it much faster. So where are we going? Beyond the digitization, because frankly, I don't want people stuck on keyboards. I want to automatically receive. So I believe you had someone from McLaren talking about wearables in one of your last talks, is that right? This is where we're going. The automation, the example he gave of anesthetic machines have been able to pump out information for years, but not many people can capture it. Now, some of my limitations is the affordability to develop that stuff and the affordability of our customers to pay for it. I don't offer a two-tier system like we do in health. If I have a problem, I know I could probably get treated in 18 weeks because the law says so. But if I want to get treated tomorrow, I can accelerate that by paying a different price. I don't do that in IMS. Everybody just gets treated the same. Everybody is equally important. Now, the challenges have already been spoken about. We do have to change. I had a question here for you also, which was, do you believe that open source is a power for good, that we can use it for positive change and transformation? In the interest of time, I'm going to answer that question. We have to. But how long will it take? Now, interoperability has been spoken about, and I would say more than open source, interoperability is the single biggest thing we've all got to do. Writing software code, honestly, is dead easy. but making it interact. And from cradle to grave is what we must do. I specialise in acute. We do other stuff too. But to interoperate with primary care, community, etc. That's where pace is starting to happen. And if we can unlock some of the great examples, then we really can accelerate things. Because you can talk about having to speed up. But believe me, that talk will not make it happen alone. You have to enable it. Now, just a couple of slides left. I believe, rather than being patient-centric, the patient is on a journey, whether it's acute, whether it's chronic, from left to right. If that patient is safely managed through their care, we will collect data, and it should be able to help us improve. So the green line is current Maxims product set. There are over 4,000 screens in the Maxims product. It's really comprehensive. But we will be able to better manage referrals, KPIs, and provide information for that population health management. Dashboards, and I'm going to come back to genomics. Below the line, I've got things like patient experience, PROMs, things that are a bit more scientific than that. The billing, the absolute patient, not patient-level costing, patient activity costing. We were doing this in the private sector 25 years ago. What we didn't have was the clinical information around that. Talent management, as we call it. Talent management, as we call it nowadays. This is a people business. Most of my photographs have got people in them. Software is a people business. Healthcare is a people business. And we know we've got the biggest workforce. I think we could do an awful lot better in looking after our generations of workers. And then ERP, the finance bit. So what we've started to do is encourage people to look longer than this month and this financial year. Now, I know Simon Stevens gave a 5-year forward view a couple of years ago, and now the local roadmaps are looking at 5 years. And I know David would like it all done in the next month, and so would I. But the reality is, adoption across big hospitals and communities is going to take several years. And what I'm appealing to CEOs is saying the average tenure of a CEO now has dropped something like 365 days in the NHS. What change can you realistically, and what legacy can you provide for your community? And what I'm saying to them is, look further out, and we are individually writing business cases at each of these areas to say, you can't say you can't do it, you actually can. And what I'm trying to do is things like the adoption of an EPR or the change of it is, if I give you a brief example, data migration. This is a shared activity between a hospital and a supplier. And in Taunton, we had 7 million patient records. We had a supplier that just did data migration. They said it'll take 2 years. I said, no, you misunderstand. No, they said, you do. We've done it loads. It takes 2 years and it costs this much. I said, no, you misunderstand. We'll be doing it in 6 months, but it'll be ready in 3. And guess what? We didn't work with that supplier. So I get data migration of 7 million records, and we failed. We failed 8 times. It took me 41 minutes, my team 41 minutes, and they transferred 7 million records, and 8 didn't match. That's good enough. And it can be done in 3 months, but I'd like to do it in a day. That's where I'd like to get to, where Steve Jobs took your record collection and put it in your pocket. I'd like you to choose your computer system and have it set up in a day. That's where I'd like to get to. So we're expanding our platform, and we're working with other partners so that this is about real-time analytics. It is about immediacy and scale. So we can talk on that on another night, perhaps. I think the direction of travel is where the Medicis were, probably several hundred years ago. It's personalized precision medicine. So Chris, I want you, at your age, I want to know how to treat you and what's wrong with you or what's right with you precisely at the moment that you need it to. And that's where I think we're all on a journey to be and should be. And that's coming back to that genomics area. It frustrates me how the government says there's 100,000 genomes, go map them and fix it, and we're still writing on paper towels. So our job is to try and balance things between the two. I'm going to finish on this, and I don't know if, I'm really sorry, you should never put a screen up that no one can read, but I didn't know how big it was going to come out. If anybody has heard of the Roosevelt, it is not the critic who counts. Has anyone read that? You might look it up. It's about being brave and being courageous. So my call to you, my request to you is this. The adoption of open source in the NHS hasn't started. I put that to you. And if you believe in it, and if you believe that we can accelerate its use, then I call on each and every one of you to talk more about it, promote it, get more involved in it, because we need people to take it up. It could thrive. At the moment, it survives. And it's a very select few who are interested. But I think if you're taking anything away from tonight, and you believe in it, and I believe it can, because if it does nothing else, open source isn't the answer to everything, but I'm trying to push the standards up of the closed source operators as well. And it's really interesting, if you look at the global digital exemplars, how many of them are not from these shores. And there's some really great Anglo-Irish, built for the NHS software that you don't have to travel 3,000 miles for and pay some of their fees. And I bring all that back to the acceleration of what we're trying to do is just help everybody on their journey in the small amount of time that we have. And with that, I'll thank you very much for your attention.